morning, everyone. I think we can get started. It seems like everybody's in from the waiting room. Thank you for joining us this morning. My name is Melissa Pennell, and I am the Director of Member Engagement at the AMA, and I'll be your moderator this morning. Before I turn it over to Dr. Parks and Dr. Peterson, I'll just take a minute to read the AMA's Land Acknowledgement Statement. Next slide. Thank you. The AMA respectfully acknowledges that we are privileged to live and work on the traditional lands of diverse, distinctions-based Indigenous peoples, including the Anishinaabe, Dene, Nehiyawak Cree, Niitsitape Blackfoot, Otipemisiwak Métis, Sioux Nakota, Stoney Nakoda, Tsuut'ina, and more. This land has been gifted with many names, including Treaty 6, 7, and 8, the Métis Nation within Alberta, its Otipemisiwak Métis government, the 8 Métis settlements, and its Métis Settlements General Council and Homeland of the Métis. The AMA honors the vibrant histories, languages, and cultures of the First Nations, Inuit, and Métis peoples of Turtle Island, now known as Settler Canada, who came before us and continue to thrive here today. And with that, I'll turn it over to Dr. Paul Parks, President of the AMA, and Dr. Troy Peterson, President of the AMA Section of Internal Medicine. Please go ahead.
Thanks very much, Melissa. And good morning, everybody, and thanks to everyone to be here early on a Monday morning. In recent months, AMA has been working to discuss and talk publicly about the escalating crisis in our acute care system. And I've compared the acute care system to an aneurysm that just keeps growing and it's getting ready to burst. And there are massive issues everywhere. And but what we're talking about specifically today has big ramifications for patients within our hospital system and in an area of medicine that most people don't really know exactly what we're talking about when we talk about internal medicine. Almost every specialty, and typically they look at adult patients who have more than one problem at the same time. Often these patients have multiple issues, they're more complex, and these issues overlap, creating medical concerns that make it more complex and difficult to manage these patients. And that's why our general internal medicine colleagues are everywhere in our acute care system. And if you're in the hospital with any complex needs, and any time of the day, even in the middle of the night, if you're not talking to an emerge doc or a surgeon, it's almost certain you're talking to a general internal medicine that's at your bedside. So because they do so much and practice so broadly with such specialized expertise, they really are the canary in the coal mine for what's happening within the hospitals and on the wards, and how our hospitals are functioning and flowing. And for almost a year now, we've been warning the government of a concurrent crisis in the acute care system. We've definitely been focused a lot on the primary care crisis as well, but we've been very clear that the concurrent crisis in the acute care system is different. They have overlapping features, but different solutions. And so today we're going to explain further what some of the specific issues that are impacting patients and what's happening with general internal medicine in the hospital. I'll say that I work very closely with my general internal colleagues in my role as an emergency physician. And, basically anybody that's sick that requires to be hospitalized, a lot of times we'll be interacting with them in the emerge and then handing over the care to them. And so I have massive respect for what they do. And I also can see firsthand the immense pressures they're under and what they're dealing with, and how much they're struggling to maintain the hospital system. And I know that basically myself, I can't do my job without them, but nobody actually can. Even preoperative surgeries, almost every component of complex healthcare in the hospital relies on them. So it's critical. And you may have seen as well some recent social media about the overflowing capacity in the Edmonton zone even, and we can talk about that more too. But when you're talking about teams that are normally staffed and have resources to take care of 100%, and they're at 150% for months and months, something's got to give. So with that in mind, it's better for me to hand it over and let Dr. Troy Peterson, the AMA Section of Internal Medicine President, speak more directly about what they do and what some of the issues are, and then we'll open it up for questions. So over to you, Troy.
Thank you, Paul. So I'm going to give you a bit of a primer on what general internal medicine is about, especially in the acute care setting, because I'm sure that a lot of you wouldn't be familiar with our job. I'm a general internist in Calgary. I primarily work out of the Peter Lougheed Hospital as well as in the community. And so as Dr. Parks explained, GIM specialists have a unique role in the hospital, as well as in the community. In the acute care hospitals, GIM specializes in the delivery of care to patients who have high acuity or medical instability, increased complexity, and diagnostic uncertainty. We care for the most complex patients with overlapping medical issues. That might include COPD, heart failure, diabetes, cirrhosis, kidney disease, acute drug poisoning, or alcohol withdrawal. Our care is provided in partnership with other admitting services like family physicians doing hospitalist work, ICU physicians, and other admitting teams, but pressure on any other area directly affects our capacity and our census. We generally do not do procedures and we do not do surgeries, but when physicians who do those services put up barriers to protect their workflow, there's often a transfer of expectations to our group. The ability to manage chronic medical conditions has improved to a point where patients will live long enough with one chronic disease to develop several. The care of these patients is more complex and a new expertise is emerging that is of very high value. The ability to simultaneously manage multiple chronic diseases, well, this is general internal medicine. When a patient arrives at hospital and is reviewed by our emergency room physicians, a decision may be made to admit that patient to hospital. In some cases, there's an obvious path to admission through obstetrics, psychiatry, or surgery, but often there's a less obvious path. Patients admitted generally need a combination of diagnostic workup to identify what the problems are, and management that might be surgical, procedural, medical, or a combination of these. From there, an admitting service is required so that a physician and care team can assume responsibility for that patient's time in hospital. Sometimes this tracks along specialist expertise, but increasingly it's moving towards being divided around acuity, complexity, and the need for coverage of acute care patients after hours. Now, just for contrast to an admitting service, a consulting service is often only able to maintain their capacity as consultants by being less involved in the admission of patients. Their capacity is saved through fewer responsibilities for daily care plans, care team and family interactions, and discharge planning. There's also fewer expectations after hours and on weekends, so their coverage models will require fewer staff. Increasingly, admitting services in hospital are being asked to do more with less, and coverage models across acute care are dangerously thin. This is no different in GIM. There are locations in Alberta where GIM physicians cover gaps in on-call coverage for other services. In some places, physicians are being asked to independently cover patients 24 hours a day for several days in a row. And some centers where the most complex and unwell patients are being covered by physicians who've been asked to cover an unmanageable number of patients or patients who are outside their skill set. The potential consequences of these actions are inevitable. They will lead to bad outcomes for patients and unsustainability for physicians. Dr. Parks said that the GIM is the canary in the coal mine for acute care. And there are many critical teams of physicians and non-physicians in hospital, and they are all seeing the same negative drift in our ability to care for patients. GIM fills a very unique role in the acute care system as we often shift to fill gaps for the most complex and vulnerable patients. This has hidden some of the imminent disasters when patients are diverted from rural hospitals or other sites, acute services have no coverage or are critically understaffed, or there are surges in acuity as we've seen with COVID and other crises. We're now at a point where many hospitals' GIM teams have run out of both fingers and toes to plug these holes, and we no longer have passed the capacity to help. Provincially, we can no longer even cover the work that we're meant to do. And when Dr. Park suggested that when GIM goes down, so does the hospital system, there's really no one that can provide the care that we do to such a broad range of patients at that volume. If any one hospital had a significant reduction in GIM services, that hospital will not be able to solve that problem internally. These patients will end up being diverted to other hospitals where their capacity would already be maxed out, leading to another system failure. And this chain of events will quickly spread across the province, impacting on every hospital. Our population is growing and the baby boomer bubble is aging. These alone signal the need for a natural increase in capacity. With increasing numbers of patients in acute care beds waiting long-term care and a slow increase of patients that we deem as hospital dependent, those who would decompensate quickly away from acute care, the flow out of hospital is quite slow. We are also now seeing the effects of where patients delayed seeking care during the COVID crisis. They're arriving to hospital with more advanced disease and more complexity. Many have also lost trust in our system. We are seeing the effects of marginalizing those who are already vulnerable. We are seeing the impact of a primary care system that has been unable to meet their basic care delivery objectives, let alone deliver on support, surveillance, and prevention for our population. Every patient presenting to the emergency room represents the story of how our healthcare system has failed that patient at some point. Taken collectively, the stories from the patients in our inpatient census would give a very comprehensive diagram of how and where our healthcare system is failing. All points of failure in healthcare lead to acute care admissions. What are the workforce factors? Well, there's an immediate crisis in after-hours coverage of the acute vulnerable patients in hospital. And unfortunately, there's very few physicians with both the skill set and the capacity to add additional evening and weekend work to their schedule. There is no option but to incentivize this work to make that, mobilize that small group of physicians that are able to do it. This is a critical need for after-hour support at almost all of our hospitals in the province. Many subspecialty services have adapted to the consultant and procedural roles without any increase and often a decrease in direct care of patients in hospital. Our incentives have shaped these behaviors, leading some subspecialists to move entirely away from hospital-based care of their subspecialty patients. Through government and Alberta Health Services, the only tool offered to change physician models have been the creative use of billing models and existing payment structures. Not surprisingly, this has led to models that are not durable and often the most expensive version of a solution. Most critical to patient flow, coordinated care, disposition planning, reducing admissions, and the probability of having a good patient experience in hospital. Good patient experience in hospital, we need to have these teams of non-physicians supporting our work. Team-based medicine is critical in hospital. The expertise of pharmacists, physiotherapy, SLP, social work, nursing, nurse practitioners, physician assistants, and other professionals have clearly been shown to improve outcomes. In some hospital, the role of medical students and residents is also critical to these models. When fully staffed and integrated, we get good results. Staff shortages, absences for illness or vacation, and just the absence of funding for members to complete a team make these teams fail to produce the best results. Many in these teams do not work after hours and weekends, so continuity is low. Many of these jobs, when the care team member is not present, are transferred to the attending physician. The impact on our efficiency and capacity of our physicians should be obvious. Imagining further that on any given day, it's a surprise to find out who's there and who's not on your team. The absence of a multidisciplinary schedule integration and transparency is embarrassing for such a big industry like acute care. The consequence of all this is more patients in hospital waiting longer for their care. The instability and lack of coordination are not only costly for the system, but they're unsafe to patients. Our healthcare system teams do their best to provide excellent care, but the glue holding these teams together is crumbling. What can we do today? Well, we can tackle the inefficiency and lack of coordination in managing people who work in the system. Let's get a handle on who's working, what they're doing, what they can do, and if they're working at full capacity. It makes no sense to run a hospital without this information. Healthcare is often about putting out fires, but if that is the sole focus, then the collateral water damage will even make the most robust systems fail. Our solutions need to have an eye on the future, where building teams will be central to the delivery of care, and we will learn from those systems that work and then scale them instead of increasing the pressure on them until they do fail. The healthcare system must also have an eye on value. We need to analyze what is needed and what is not, and be able to let go of low-value models, allowing for the exploration of alternatives. This is not an easy exercise, but the complete absence of this activity in this space will continue to allow us to provide mediocre results at the highest possible price tag. Working in a highly empowered, well-functioning team to support patients is one of the most rewarding things anyone in healthcare can do. That is not the experience we have today. General internal medicine physicians are already running on fumes, and we are continuously being asked to do more with less. We are optimizing for crisis management, and at this point, we don't feel that we can carry on much more unless we get some immediate assistance. Our role in hospital has been under-supported and the role in the community devalued as unseen collateral, with a growing negative impact on its absence of the ability to support our patients outside of hospital. GIM physicians need to reestablish a workflow that optimizes their unique skill set and rebuilds the practice diversity that defines our specialty and inspires the next generation of physicians to follow in our footsteps. Thanks for listening and spreading our message.
Thanks, Dr. Peterson. So we'll now open it up for Q&A. We'll conduct the Q&A using the hand raise tool in Zoom. So if you have a question, please just use the hand raise button and we will obviously go in the order of hands raised. When I call your name, please come off mute to ask your question, and also remember to introduce yourself and just let us know which media outlet you're with. I think first up, it looks like we've got Michelle Bellefontaine. Please go ahead.
Hi there. I hope you can help me. Help me with some information. Hear me, I meant to say. Sorry about that. So what solutions are you looking to government to provide?
Well,
Go ahead.
Yeah, we have a few things that are very urgent. I think the most pressing concern at hospitals that are imminently failing is going to be, what are we doing to support the care of patients after hours? If we don't do that urgently, we're going to lose the capacity to look after patients during the daytime, and we're going to have patients doing poorly overnight, and some bad outcomes are going to happen that could be avoided. So a critical first step is making sure that we have that safe, competent after-hours coverage. The second thing, I think, is doing an inventory of the teams that are most effective at delivering the best care, the most efficient care, and the most cost-effective care. If we don't know what that looks like, we need to spend some time doing an analysis of that and then working towards creating those teams. I realize that can't happen because every system is stressed as we are, but we do have to identify what that looks like and then figure out how to prioritize around that.
Yeah, and I'll just add, to be even blunt, specifically, so the AMA identified this over a year ago. This has been issues that have been growing for years. There's no question about that, and exacerbated in the last couple of years post-COVID because of workforce challenges. But we gave government in the fall of last year a hospital stabilization plan that clearly highlighted and said, these are some of the struggles we're going to have, and specifically after hours, incentivizing after hours care. So these hospitals run 24/7, and you have the right teams and the right people in the hospital to care for our sickest patients. And unfortunately, government has not moved at all, not one step on that plan. And now we're going into a fall that normally in August, our volumes go down a little bit. Our teams get a bit of a breather. We have a bit more capacity. We're already overflowing in capacity in almost all of our major hospitals, and worse in some areas. And this is pre-fall, when we know the cyclical volumes are going up. And so we know we're in trouble. And so we need government to act and invest, and we can't delay anymore. So just to be really blunt, government has some solutions we've given them. It can't wait any longer. They need to invest in some of those components.
Thanks, Dr.
I'm wondering, as a follow-up, what are some of the measures that you propose to government?
So a couple of pieces in that stabilization. So part of it is actually looking at, so the incentivize, but basically funding around after hours now is becoming, it's been neglected for about 15, 20 years, to the point where it's made a lot of changes where a lot of our subspecialties are working solely in the community, and now it's actually not only it's actually a disincentive for them to come in and help in after hours. Same thing for the teams that support the after hours care. Those kind of pieces, we were very clear saying, if we don't start to correct this now, you're not going to have the adequate physicians and supporting teams to run 24/7. I'd also say that we actually really have to focus on some of these key solutions to stabilize our acute care system right now, because unfortunately, Alberta Health and the government has been spending more money and more time on consultants and refocusing the system than they have on solving solutions that would make Dr. Peterson and his colleagues be able to actually care for the patients in our hospital. And again, it really needs to be stressed that this isn't just about the sick patients admitted that are currently in hospital, because if we can't blow and get them out and get them to alternate like long-term care, get them healthy and back out, all the new patients, surgical patients, cancer patients, our emerges are overflowing because Dr. Peterson and his teams and the general internal medicine specialists and hospitalists, they can't do their job at this point with the capacity struggles they're faced with. So it's complex. There's not just one thing we say, if government does A, everything's going to be fixed. But honestly, if government doesn't even start with A and doesn't act and actually make some changes, we're just going to get worse and worse.
Thanks, Dr. Parks. Next up, we have Nadia Mohari. Please go ahead and come off of mute to ask your question.
Hi, can you hear me?
Yes, thank you.
Yes.
Thank you. You guys are painting a pretty scary picture for everyday Albertans, and you're talking about how you have given the province an outline of a sort of game plan to address things, and it's been ignored. And you say it's complex, but I'm wondering, what can we do in the short term? I don't know if it means we need more doctors, we need more money. What are things we can do in the short term as a solution that the government's obviously not doing?
Troy, you want to go? Or?
Yeah, I think this is something that it's not a new problem. It shouldn't surprise anybody that these issues are happening. And what we need to do in the short term, what we haven't been doing, is figuring out how to expedite the path of patients through hospital and support them outside of the hospital. I think we've neglected so many things that are what I would call the acute care halo, which is the care of patients outside of hospital that keeps them out of hospital. And now we're seeing the trickle down of that, which, as I said before, all roads in health failure lead to acute care. So now we're seeing that we're bursting at the seams, because in so many different areas in healthcare, our system is failing, and eventually the hospitals just don't have that capacity. We do need more doctors, but honestly, I think we need more capacity within the physicians that are working. And to create increased capacity, you need to have better teams. And there's nowhere that's more important, I think, than in hospital. If you have better teams, you increase capacity and you increase efficiency, and you have physicians working within the things they do that are unique and valuable, and you have allied healthcare workers doing things that they have expertise in. I think we really need to look at that model and support it. And funding is short, hirings are short. We need to look at not just after hours and weekend coverage for physicians to be incentivized, but maybe for some of these other allied health people to be incentivized, because it's odd to all of us that the hospital has a weekend. It doesn't. Everything happens the same on the weekend. And what we don't recognize is that when patients' care plans stall on the weekend, on the other side of that for our most vulnerable patients is a longer hospital stay.
So,
yeah, so if I can just add, I'll just add to sort of be very specific though, what could they do right now is that investment up front of incentivizing the after hours care and the teams, but also this government actually said, the premier stood up and said they did not put in the 2024 budget enough money for inflation and population growth as an example. So so right now, AHS has no control over the budgets. They are at the mercy of what the government budgets on this. Right now, we are inadequately budgeted in the healthcare system in the acute care for our physician funding. That's been 15, 20 years delayed and hasn't moved, but also our teams. And as Dr. Peterson says here, that if you don't have discharge planning and physio and pharmacy and all these other teams, including nurses, then the care gets delayed, patients stay in hospital longer, our capacity gets stressed more, and it's just very, very inefficient to the point where it's actually costing us way more money because the government's chose not to invest upfront in these solutions.
Sorry, I just want to clarify. So if you were going to call on the government to do anything, would it be incentivizing these specialists so that more of them would work weekends and overnight so that it can help the system? I just want to boil this down to something that is really an actionable demand on the government?
Yeah, so actually within our plan, there's probably 3 or 4 components again, but within there specifically, the acute care stabilization, it actually highlights pieces of that are funding related, that are actually, specific funding for after hours care as an example. A second piece of that would be workforce planning. Right now, absolutely, we don't have any coordinated workforce planning process in our province right now to look at where are subspecialists working, where are specialists working, what teams are supporting them. We don't have a coordinated piece on that. That's something we've been advocating for over a year as well. And they have to go hand in hand, right? You have to do some upfront investment right now, funding, specifically incenting to bring back physicians. And it will take a collaborative, and when I say bring back physicians, I mean, there's some that are working out and providing a very valuable service in the community, but at the kind of expense of the prioritizing of our expensive non-flowing hospitals. So we've given them these very specific solutions, and right now nothing is progressing on it, like nothing. So that's why it's so critical that we're raising, and within there's multiple other steps and things we have to do. It's not one thing is going to fix everything. But again, we're probably 8, 9, almost 10 months out, and we haven't moved on the plan that we gave them. Nothing's progressed.
Thanks, Dr. Parks. Thanks, Nadia. Next up, I've got Lana Michelin. Please go ahead.
Hi, I'm Lana Michelin from the Red Deer Advocate. Red Deer Hospital has some unique challenges because there is no other hospital in our area which serves like close to 500,000 people that provides acute care to the level that Red Deer does. Could you please talk a little bit about what this problem means for communities in central Alberta?
Yeah, well, I mean, it's the same struggle that's hitting everywhere in Alberta right now. Part of that is exactly like, again, it's so complex that if I were to say if government just did our acute care stabilization plan, would it fix everything? No, it would make some major steps forward in helping us stabilize things. But of course, there's going to be big picture things like investment in continuing care and long-term care, like Dr. Peterson was talking about. About 30% of our capacity in our acute care facilities now are designated alternative level of care, meaning they're safe for discharge, but they can't go home safely without some support. But so what I'll get to Red Deer for you is that exactly. They're going to build a hospital that's going to take a couple years to add some acute care capacity. That is necessary, but unless they can, that'll take years. Like you're probably in the 5 years. I'm not sure when they're opening, but in the meantime, what they have to do is actually align some of those incentives and team supports in the Red Deer Hospital so that they can actually have a function at the capacity they're at now, get patients through, because that'll have a trickle effect. It's going to hit in the fall that the little small communities in the surrounding area and central zone that refer to Red Deer Hospital, they won't be able to send patients to Red Deer Hospital. They'll have to keep those sicker patients in the smaller communities with less resources because there just will not be capacity to surge to accept those patients. That's the ramifications that's occurring right now in an area like Red Deer, for example.
Just to clarify though, like Red Deer Hospital has had staffing challenges. Like we may not have enough general internal medicine specialists to cover the kind of coverage that you're talking about. So could you say, like in the absence of enough internal medical specialists, what are the teams that you're referring to, and is there some other approach that can be used if we just don't have the expertise to cover all the shifts?
Yeah, and I think that's something that Dr. Peterson was alluding to, as well as with so again, that's why the last year we've really focused on that, being able to retain and recruit within Alberta, doing a workforce plan and really making sure we're competitive for the funding model so we can incent that type of care. That's been a focus for a long time. But in the meantime, yes, we're going to have to look in a coordinated fashion of, are there some subspecialists in, so when we say pulmonary, GI, all of these different subspecialists that are providing very critical services and are very busy, are there ways we can incent them to be able to help take care of patients in the hospital? So for example, if they have complex heart disease, could they do some admissions and extra work in the hospital to relieve some of the pressures for Dr. Peterson and his colleagues that are already struggling. That's a first step, and that would take some of the funding suggestions that we've made and realigning some of the incentives. But the second is absolutely looking at a coordinated, what are the nursing, even just starting with nursing, what's the nursing workforce you have, what's some of your discharge planning and your transition, and like things like OT and PT, what are the teams that are built around that? And is Red Deer Hospital adequately funded to actually ensure that those services are provided? And again, that's going to take some very significant provincial coordination, because everybody's struggling right now, and this has been neglected for a long, long time. Dr. Peterson, do you have any thoughts on adding to what I'm saying?
Yeah, Red Deer has struggled for a long time with keeping up with their population growth and their needs. And I think they have done a good job recently in recruiting some physicians. But as you alluded to, the problem is, what do you do after hours? Because working these physicians in Red Deer around the clock, week after week is not a sustainable model. And one of the things that I think is really critical to highlight is you can't just plug any physician into that system and say, look after patients after hours. It's the management of an acutely unstable patient in hospital is a skill set that not all physicians have. And it may be something that there's some physicians that are uniquely skilled to do that in Red Deer that aren't general internal medicine physicians. That's certainly not unreasonable to assume, but you can't just bring in patients or people to fill that need that don't have the right training, or you're going to have problems overnight. So we need the right people that are competent at dealing with this high level of acuity that Red Deer sees, that Grand Prairie sees, that Fort McMurray sees, and Medicine Hat, and all these places. The problems are sort of different in Calgary and Edmonton, but when Red Deer has pain and struggles, we feel it here because there's diversion. They're not able to provide coverage and service. Some of the expertise from Calgary goes there, not enough. Like I get it. And I do feel for a place like Red Deer being the canary in the coal mine, because they've done more with less for longer than the rest of us, for sure.
Thanks.
And I would just reiterate again that I understand that what you guys are trying to nail down, and it is a bit, I share your frustration in that I wish it was just one thing. But again, I'll just re-stress that we've been talking about this for about 10 months, but really it's been building for 5 years, and we need to start to have some action on it, some first steps and some movement on some of these pieces in a coordinated effort, or we will just continue to be in a worse situation from month to month.
Thanks, Dr. Parks. I think there are no further hands raised, so maybe going once, going twice. All right, with that, thank you so much for joining us today. If there's any follow-up, as always, please don't hesitate to reach out to media@albertadoctors.org, and have a good day, everyone. Thank you.